teruskan. Selamat pagi semua and Assalamualaikum and good morning to everyone. Today is the first lecture in a lecture series of 4 lectures about global health. My name is Swee Keng and I'll be taking you through the next hour and a half or so. So I might begin by saying that I've not heard the UKM anthem for about 10 plus years right now. So it brings back very many fond memories. And I wish sometimes that I was back in university with all of you. So what we will do today is to have a quick look at health systems of Malaysia. This is the first lecture of 4 lectures in a lecture series on global health. So welcome to the lecture series and welcome to the first lecture. As usual, what I would like to do is to take a minute or so just to set some ground rules for how we will interact going forward. We have, say, some maybe 2 or 3 portions in today's lecture. The first portion will see me take you through the theory of it for about 30-45 minutes or so. And then we'll have a short question and answer session. And then we'll go on to 2 case studies, per the requests made by one of your colleagues last week. So we'll do 2 case studies where there will be a lot of conversations, and then we'll end with another 15-20 minutes of a Q&A session. And then we'll finish precisely on time at 11:30 in the morning. We will not take any breaks, so we'll continue going. But if you need to excuse yourself to stand up and stretch and use the bathroom or anything of that sort, please feel free to go ahead. After every 1 or 2 slides, I will have a look at the chat function. Sorry about that. I'll have a look at the chat function just to make sure, just to see if there's anybody who wants to ask any questions or anything else that you want to say or ask. Yeah. If I may make a request, it is for you to perhaps put your questions into the chat function, yeah, rather than the Q&A. So we'll centralize everything into the chat function. So I'll be only needing to check 1 area rather than 2 or 3 areas. Okay. So with everybody's permission, we'll get started. We have got 26 participants, it looks like. And I'm very, very pleased that you're here. Thank you for spending your Saturday morning with me. We'll begin. And in the first instance is to really talk about the difference between science and the arts. And this short introduction between the differences between the sciences and the arts will anchor our conversation today and also the next few days, or the next few Saturdays rather. All of you are medical students currently. You are a student of the sciences. You study biology and biochemistry and anatomy and physiology, and everything's very laid out to you in a way that you just have to digest and memorize the information. However, in the arts, in the picture, you see the circle on the right, yeah? The arts is very abstract, it's very subjective, it's relative, and it changes very often. So therefore, because all of us in this conversation today, we're so used to studying the sciences, which are very precise, they're very absolute, they're very rigid. For example, mitochondrial function is mitochondrial function anywhere in the world. And the physiology of alkaline phosphatase and the 5 subtypes of alkaline phosphatase is exactly the same for any human being anywhere in the world. And that's just in medicine. Because the sciences are so precise and so absolute and so rigid, you may need, or we will need, different ways of thinking and learning about the arts. What we will study today and also the next few Saturdays is a combination between science and the arts. It's not as precise and as absolute as you imagine. For example, hemoglobin must be between 13 to 18 grams per deciliter. That kind of precision will be absent from our conversations about health systems, health policies, and global health. To the extent possible, I'll give you a lot of structure and a lot of precision and a lot of rigidity so that we can understand it. However, I would invite you to exercise a different part of our brain and our consciousness and the way we learn so that we can appreciate the arts in a way that will enable us to learn very, very effectively. Ladies and gentlemen, this is my opening statement to say that learning the sciences and learning the arts are very beautiful processes. They require very different ways of thinking and learning. And I encourage you and welcome you really to join me on this journey as we consider learning a different ways. All right, we'll proceed then. We'll begin with a quiz. Unfortunately, I can't really do a poll. So maybe I'll invite you to do the chat function, right? And in the chat function, the first question for everyone is, how many employees are there in Ministry of Health Malaysia? Total employees, Ministry of Health Malaysia, doctors, nurses, paramedics, and so on and so forth. I'm not talking Ministry of Higher Education, not talking about Ministry of Defense or any other ministries, yeah? So how many employees are the Ministry of Health Malaysia? If you can just type your answer in the chat group, that'll be great. Please go on. I'll have a look at the chat group in the meantime. Great. So we have a few responses. Most of them are B's and C's. And the right answer is 270,000 employees in the Ministry of Health Malaysia. And that's a lot of people. The Ministry of Health Malaysia is the second largest ministry. The largest is the Ministry of Education. For teachers and administrators in the education department, we've got something like 500,000 people. The security agencies, if you count the police and the immigration and the soldiers together, there are about 400,000 people. But if you separate them, the Ministry of Health becomes the second largest ministry in Malaysia. I have a second question for you, and this is for us to begin understanding the Malaysian health system. And in the Malaysian health system, somebody has to pay for it. And where does the money come from in our public healthcare system? It comes from general taxation. So my second question for you is, how much of our annual GDP or gross domestic product, meaning the size of our economy, how much of our economy does Malaysia collect in taxes every year? So I will say question 2 in the chat group. How much of our annual GDP does Malaysia collect in taxes? The European Union average is approximately 20% of GDP. And how much does Malaysia collect? Is it 10% of our economy, 13% or 15% of our economy? Take a guess. I'll give another 10, 15 seconds or so. Okay, so I hope you've all answered. The answer is 13% of GDP is what Malaysia collects in taxes every year. And if you're interested, you can have a look at our budget every year to see how much of it comes from personal income tax, corporate taxes, the petroleum taxes from Petronas, sales and excise taxes like GST, import taxes and export duties, and so on and so forth, if you're interested in that breakdown. Collecting low taxes doesn't mean it's good or bad. Collecting high taxes doesn't mean it's bad or good. But the concept that we will address later in this lecture is, if Malaysia does not collect enough in terms of taxes, then we will not be able to fund our healthcare system. I would like to ask you the third question right now, okay? And the third question is, if you are Prime Minister, you are all Prime Minister, if you are Prime Minister, how many percent of the government budget will you allocate to health? There will be other competing priorities. I put here in the panel in question 3, how many percent would you allocate to health? Other competing priorities would be schools and roads, public housing, social services, orang aslis, rural development, pensions, debt interest payments, arts and culture, museums, etc., etc. How much would you allocate to health? And I put there the EU average. I'll tell you what's the European Union average shortly. So you see, go ahead, and there's no right or wrong answer, everyone. Go ahead and pick your answer. Okay, I'll wait another 10 seconds or so. Such a difficult question, but also a fun question to think about, right? Ladies and gentlemen, my friends and colleagues, we do not have any right or wrong answer here. And that's why talking about health systems requires us to reach out for the arts to consider that there are right and wrong, answers that are right and wrong at the same time, and good and bad at the same time as well. So let me proceed with what I think is a reasonable answer today. Now, the question is, how much of the government budget will you allocate to health? And your answers are variously 5 or 10 or 20%. Maybe you've got different ideas and that's all fine. Right now, the Malaysian government allocates 10% of our government budget to health. This pays for salaries, this pays for medicines, this pays for ambulance services, the maintenance of our facilities in our hospitals, and so on and so forth. And this 10%, right, is only to the Ministry of Health, not to HUKM or HCTM, because that budget comes from the Higher Education Ministry's budget. Unfortunately, we're not able to see, for lack of say clear transparency reasons, how much is given over to the university hospitals in Malaysia. But as many of you, when you graduate, you will be likely working in the government hospitals of Malaysia rather than the university hospitals of Malaysia. 10% is the amount of allocations that you will receive, and the EU average or European Union average is also 10%. Now, should it be 50% or should it be 2%? These questions are very unanswerable. Yes, it should be 50% if your budget is very big or small and things like that, right? So I will not get into that conversation, nor will we discuss today what is the perfect percentage of government budget that should be allocated to health, or what is the perfect percentage of our annual GDP that Malaysia should collect in taxes? And thirdly, what is the perfect number of employees in Ministry of Health Malaysia? Because in talking about health systems, we have to understand a lot of trade-offs, and we have to understand that every decision has its pros and cons at the same time. So that's it for the quiz, my friends and colleagues. We'll move on to some didactic portion of it, right? So I'll spend about 15, 20 minutes or so taking you through a few slides, yeah, to talk about the theoretical and academic aspects of health systems. And then we'll pause for questions and answers, and I'll unmute everyone's mic, and you can always ask questions then, or you can type in your questions in the chat box. In fact, I prefer slightly that you type in your question in the chat box so that you will be, say, writing a question in very short terms, and then we will be able to go with over many questions in a short period of time. Well, let's go through the theory aspects of our health systems and, in Malaysia. We'll begin with a history. And this history is from 1957 or 1960 in this case, just at the time when we reach independence. And I sketched out a trajectory of our life expectancy until 2017, which is one of the latest years for which we have data. And you see that the number increased from 59.5 or 60 years average life expectancy or total life expectancy all the way to 75. So we added 15 years of life or 16 years of life to Malaysia, to the average Malaysian, in a space of 50 years. And total life expectancy is one metric to determine the health of a health system. But it's not the only metric. There are multiple other metrics. I'm not here to tell you that this is the only metric you could look at. You can look at other things like the disability adjusted life year, DALY, or quality adjusted life year, QALY. And you can look at other metrics like the per capita spending on health and the, say, productive years or healthy life years rather than total life years. The point being that there are many statistical parameters for you to measure the health of a health system or the health of a population. Frequently, we use total life expectancy, but other people will use maternal mortality, child mortality, nutrition rates, obesity rates, and so on and so forth. I have to simplify this because this is a 1.5 hour lecture on a very large and complex system. Allow me to use total life expectancy. What has happened since 1960 to 2017 or so is that in the beginning, our system in 1960 was very small and simple. Why? In 1960s, the diseases were mostly infectious diseases like polio, tuberculosis, malaria. People died from these kind of diseases, and also maternal and child deaths. And in the 60s, the systems were generally inadequate hospitals. We also had trouble retaining doctors in the public service because a lot of them will go into the private sector. This was 50 years ago, ladies and gentlemen. The problem that we have today of inadequate hospitals and retaining doctors in the public sector remain true 50 years later. And I'm not just quoting this. I read books rather. And the book that I'm referencing is from a surgeon, Lim Kian Kee, who wrote about the history of medicine and health in Malaysia. So the 1960s system in Malaysia was small and simple, but then our population grew, from say 7.5 million to now 32.6 million. The number of doctors grew from about 857 in 1960 or so to about 51,000 today. The ratio of doctors to population, 8,800 Malaysians for one doctor now is 1 to 600. The percentage of doctors in the public sector are now, previously was 47%, right now is 75%. This is in total, meaning from house officers to subspecialists. The number of hospitals in the MOH setting is 69 back then, and now 145. We have approximately 9 to 10 university hospitals and 5 Ministry of Defense hospitals. So in terms of public hospitals, we really should add them up, and maybe 160 or so public hospitals. And the percentage of government budget that is spent on healthcare is 8% back then in 1960, and 50 years later, it's about 10%. The details are plus and minus the same. But one important factor is that the population grew in numbers and also in age expectancy, life expectancy, and also their expectations. In the 1960s, imagine our grandparents. And I recall a story from when I was in working as a doctor in hospital Taiping. One of my patients, she delivered a baby, and she tells me the story of her mother who delivered a baby in the 1960s, delivered her rather in the 1960s. And what the mother did was go to work in the sawah padi. Then when she was fully pregnant, deliver my patient, bawa pokok, and then proceeded to go back to work. Those kind of expectations don't exist today. If you go for a childbirth today, you'll expect pain-free experience, a first-class experience, and a very comfortable, very poignant life experience. And I think as expectations grew, the system needs to change and evolve to meet the expectations of our patients. And we should meet the expectations of our patients. So from 1960s to today, what happened is that our system today, from small and simple, it is now large and complex. The diseases that we have in 2020s are different from 1960s. It's more non-communicable, maybe even mental health. And we've got 2019 systems that are potentially inconsistent in quality, with some overcrowded hospitals and specialist brain drain with high cost. Technology has come in, surgeries are expensive, some medicines could cost $1,000 a month. A large and complex system grew to meet the expectations of a larger population that's better educated, that's richer, lives longer, multiple diseases with technology as well. This is the inevitable progression of history, and that's Malaysia's health system. And this is a case study on Malaysia's health. Now, from today, if you want to go from 2017's 75.5 years life expectancy, and you want to increase it to, let me invent a number, 100.5 years average life expectancy. Whether or not somebody wants to live to 100 is an entirely separate matter, and I'm saying that this is one metric of a health system. So what must we do from today all the way to 2050 if we want to increase our life expectancy? Then we need to consider the health system 3.0 to consider the needs for 2050. That's quality of life, not just the length of life, and they're very different things. You can live longer. We can artificially ventilate somebody on a ventilator for days and maybe even months and years. But we also have new things to focus on, like the quality of life, like aging, loneliness, dementia will be major problems coming soon, and regenerative care, meaning if you're living till 100 years old, you have to consider if you need a liver replacement, a heart replacement, knee replacements, even, I don't know, nerve replacements or brain replacements, whatever technology will take us. And therefore, the systems will need to accommodate many, many more Malaysians living much longer lives. For example, we may need more community and non-hospital care rather than hospital care. We may need new labor and pensions policies. For example, the retirement age can no longer be 60, it may need to be 75. And we therefore need a new social contract as well. This is the history of Malaysia's health system and a little bit of projection into the future. But to understand the system today, let me take you to the next slide. And I'll do some definitions today before we start talking about some other concepts of what is a health system. The definitions that I would like to start with is, firstly, healthcare is different from health. Healthcare is different from health. Healthcare means you are giving medicines and surgeries in clinics and hospitals by doctors, nurses, and paramedics using ambulances and CT scans. But health is not just healthcare. So health is very big. Healthcare is just a small component of health. Health, for example, that is not healthcare or penjagaan kesihatan. Health could be environmental policies that reduce air pollution so that fewer people have asthma, or environmental policies that reduce water pollution so that fewer people have cholera, or policies that encourage more parks or natural parks or parks for jogging with adequate lighting so that people, especially, shall we say, women, feel safe to go jogging, running, exercising when it becomes dark. Those are policies to improve the health of the population, but have got nothing to do with delivering healthcare in hospitals. Health is much bigger, meaning if you don't have health policies that improve the health of a population, you will be condemned to just building hospitals and more hospitals and more doctors in order to cure diseases rather than to prevent them. So healthcare and health are very different. Penjagaan kesihatan and kesihatan are very different concepts. The definition of a health system for bullet number 2 from the World Health Organization is a very generic academic one, which is a health system is all the organizations, resources, and people who work to improve health. Now you notice here that I'm not saying healthcare system, because if it's healthcare system, it's the hospitals, facilities, doctors, nurses, and the people who work to deliver healthcare. And that's very narrow healthcare. But a health system is different from a healthcare system. A health system, looking at the definition, is the organizations, resources, and people who improve health, not deliver healthcare. So anything, for example, the JKR engineer, Jabatan Kerja Raya engineer, that invents a new material for tar roads that reduce accidents is actually improving health. Or the police officer who helps us, not the police officer, but the police department that comes up with automatic speed enforcement systems, or the police departments in Taiping, where I'm from, for example, that enforces the helmet ruling, the seatbelt ruling, the speed ruling, will also improve health. And this is what we call the health system, different from just the narrow healthcare system. I hope I've made a very clear distinction between healthcare and healthcare system and also health system. We'll then go on to the definitions of the 4 aims of patient care. Now, I would appreciate if you want to take notes here, so you can take some brief notes or whatever I say that strikes you. But this is intended for you to get an idea, not for you to memorize, but for you to get an idea that these things exist. And if you need to, you can always come back to them, and I'll be very happy to share these slides with you as well. Let me move on thirdly to say that there are 4 aims of patient care. The first one is health outcomes, meaning you want to improve the outcomes of a patient, meaning reduce the risk of diabetic knee amputations or knee amputations due to diabetic foot ulcers. You want to reduce the morbidity that comes from cardiovascular events, for example. And these are this is the first aim of patient care in the health system, to improve health outcomes. Secondly is equity. Equity, what that means is everybody receives the same treatment so that they get to the same level of health. Some people who live right next to a clinic don't need help getting to the clinic. But for our friends and colleagues, our brothers and sisters in the Orang Asli communities or the Bajau communities or the Suluk communities, or those who live in the interior of Malaysia, or even the migrant or refugee populations in Malaysia, we want to try harder so that they achieve the same health level as the rest of the world or the rest of Malaysia. The second aim of patient care is equity. The third aim of patient care is financial risk protection. In Malaysia today, although our public healthcare system, if you go to a government hospital, you only pay 1 ringgit to see a general practitioner and 5 ringgit to see a specialist. That's great. And Malaysia's government pays a lot of money for you to get, say, expensive medicines and most surgeries at a very cheap price. But still, even if you go to a public hospital, there is still the risk that you go bankrupt. About 20% of Malaysians who go bankrupt every year, I repeat the number, 20% of Malaysians who go bankrupt every year go bankrupt because of medical bills. The vast majority of them who go bankrupt is because they have unsustainable spending habits, credit card debt, they spend way too much than they earn, and then this is more a consumption problem. But in healthcare, it's probably very difficult to accept the fact, or rather, let me put it more strongly, it is unacceptable that Malaysians should go bankrupt as a result of healthcare expenses. So the third aim of patient care is actually to provide financial risk protection. And fourthly is user satisfaction, meaning if you are a patient and you go to a healthcare setting, you want to, well, you don't necessarily need the first class treatment all the time, but you should come out from the system feeling quite satisfied that your doctors were kind to you, that the system was working, and that you didn't have to wait too long a time, and that you didn't suffer too much as a result of using the system. These are the four aims of patient care. The fourth definition I wanted to provide is the idea of universal health coverage, which is an ability to access care without financial catastrophe. UHC, or universal health coverage, not universal health care, but universal health coverage, means that if you get the care that you need, you should not go bankrupt. These are the definitions I wanted to share with you today. But let's look at the functions of a health system. Now, we understand over here that health systems are the organizations, resources, and people who work to improve health. Let me tell you what are the functions of a health system. The first function of a health system, which is on this graph on the right, is that health system delivers health, meaning it improves health, it improves relations health, it helps people lead a better and stronger and healthier lives. All that is very true. But they also fulfill four more functions. Let me pause here for a second just to check that if I need chats. Okay, I'll sorry for that. I'll proceed. The health system in Malaysia also fulfills four different functions. I'll go through them very briefly, and the task today is not to tell you about what functions that they fulfill. The first one is they are a social institution. What I mean to say is, partially the reason why Malaysia has a national identity was because Tun Abdul Razak, the second Prime Minister of Malaysia, had a conscious strategy of national development, which means including building many clinic desa and clinic kesihatan. So today, 85 or 90% of Malaysians live within 3 or 5 kilometers of a government health facility. That means that it's an institution that allows us to have a shared experience of going through a clinic kesihatan. Today, very few people don't have experience going to a clinic kesihatan. Of course, there'll be a small minority who only go to the private hospitals, and I guess we will never be able to force them to go to a clinic kesihatan. But the point being, if 95% of Malaysians have experience going to a clinic kesihatan, it helps unite a country. The health system in Malaysia is, and every other country, all countries in the world, is also secondly an economic institution. It's a place where we buy a private GP or a private hospital. There's a buy and sell transaction. When you work in a government hospital in Kementerian Kesihatan, you are a salaried employee of Kementerian Kesihatan, and therefore you are part of the economic institution. The Ministry of Health every year purchases, I think it's about 3.2 billion with a B, ringgit worth of medicines. That money goes to pharmaceuticals in Malaysia, like Pahang Pharmacy and the YSLs of the world and Pharma Niaga, who make medicines for Malaysia. And therefore, that's also an economic component as well. So a health system is not just I give you health, but it's social, it's economic. Thirdly, it's political. It's political in the sense that there is a social contract. For example, you pay 13% of your salary for taxes every year. In return for the 13% of taxes, you get public services like education, subsidized healthcare, tertiary hospitals, ambulance services, emergency. You know, when you call 999, somebody has to pay for the service of hiring the people, maintaining the phone lines, and ensuring that these people are trained, for example. And that political institution comes when you have a contract, a social contract between a taxpayer, what the taxpayer gives and what the taxpayer receives. And therefore it becomes political. And fourthly and finally, a health system is also cultural. Because if you have the same health system that works well it means that 32 million Malaysians have life experiences in a government hospital that is relatively similar to one another. And we may study the science, like I mentioned, with mitochondria and alkaline phosphatase and diseases like progressive multifocal leukoencephalopathy, which is a sub-disease. It's an AIDS-defining condition, for example. We study all the science and it's beautiful, the pathophysiology and so on and so forth. But let me tell you about the culture, and this is how beautiful a health system is. When you are born, you go to a hospital, and nobody remembers the hospital, they remember the birth. When you are sick and you are suffering from pain, you go to the hospital. They don't remember the hospital, but you remember how you feel when you're suffering in pain, having disease, and your body is decaying, and you're in the hospital. And when you're dying or when you die, then you're also doing that often in a hospital, or you have multiple touch points with a health system throughout your lives. And these touch points are very emotional, very spiritual, almost religious touch points: birth, death, dying, and disease. And a health system shapes our attitudes, like Malaysia, towards very important life events like birth, death, dying, and disease. And these are very important functions of a health system beyond just, I'm going to give you healthcare. So when you have this broad view of a health system, it allows you to understand how you should make policies and how you should understand global health. This is, after all, a lecture series on global health, but we will be served well if we understand the functions of a health system beyond just delivering healthcare, giving you medicines, providing surgeries, and helping you deliver your children. There are social, economic, political, and cultural reasons why health systems are very important. Now, this is quite a lot of information, and like I promised you earlier, very little of it is scientific. It's not the pathophysiology or the circle of Willis, for example, in the brain, but it's a combination of science and the arts. Now, I'm going to stop here for 1 second to look at the chat function. There are no chats at the moment. If it's okay with you, I will proceed. We will talk in the next slide. This is the next slide already. Very briefly, to continue about a health system at a very macro perspective, and then zoom into the micro perspective. And this is I believe, the last slide, and then we'll stop for a while, do Q&As, and then we'll move on to the case studies. This is the last slide, yeah, before the case studies. Allow me to tell you about the healthcare trilemma. I'll begin with a story. All right, so how many of you have a car? So you may or may not have a car, or you may or may not have a motorcycle that you use currently. So when I was in UKM, I had a motorcycle that I used for 5 years. So some of you may be lucky and you have a car. But if you don't have a car, your parents may have a car. If your parents don't have a car, for example, then you may have a refrigerator at home. Okay, so think of these few ideas, okay? So the car or the refrigerator or the air conditioner, television breaks down and you want to get it serviced. And when you want to get it serviced, the technician will tell you, if you want good and fast, it will not be cheap. If you want fast and good, if you want good and fast, it will not be cheap. If you want cheap and good, it will not be fast. If you want good and cheap, or rather fast and cheap, it will not be good. And that's the trilemma of good, fast, and cheap that you face on a daily basis. In healthcare or in health systems, there is also a trilemma. The trilemma is between quality, access, and cost. And it's easy to remember, QAC. QAC is quality, access, and cost. And you can instantly see the trilemma. If you want to improve the quality and if you want to improve access, meaning more people have access to healthcare, then the answer, sorry, I'll just go back a little bit. If you want to improve quality and improve access, then the cost will be high. If you want to reduce cost but increase access, then the quality will be low, and so on and so forth. The permutations are such that QAC, or quality, access, and cost, QAC, is similar to the real life problem that you have of good, fast, and cheap. Good, fast, not cheap, fast, cheap, not good, and so on. That is the healthcare trilemma. And you have to pick two, meaning high quality and high access must be high cost as well. Or high quality, high cost will be low access and things like that. It's very difficult to resolve a trilemma. And because it's so difficult to resolve a trilemma, Remember, I told you in my first slide, there is no perfect answer to anything. And it's all a matter of balancing these trade-offs. That's the macro view of a healthcare trilemma. Sometimes also a health trilemma, but in this case, a healthcare trilemma as you deliver healthcare to Malaysians and you have R1 billion to spend, for example, where do you spend it on? You have a lot of dilemmas and all your answers will be good and bad at the same time. We have to minimize the bad and maximize the good. That's a very macro view, yeah? I'll move on a little bit to talk about some format of thinking about a health system. A health system is so big. Now, when I tell you about the health system in the previous slide, everything's a health system. Every ministry is a health ministry, for example. So then we're now, academics have now come up with this 6 building blocks of health systems intended for us to understand how to structure our thinking. So I'll provide these 6 building blocks to you over here. Again, you do not have to memorize this. If you Google up 6 building blocks of health systems, so you will see the 6 building blocks, and the building blocks are very intuitive, yeah? So when you see them, you will instantly understand. The first one, you instantly understand how they are and how they interact with each other. The first building block of health systems will be the workforce, meaning the human capital or the health workforce. These are different terms for the first building block of health systems. Well, I say the first building block of health system, but it assumes that the rest of them are not important. That's not true, because they're all interchangeable. I can't say that workforce is number 1, but I also can't say that workforce is number 6. I think all 6 of them are equally important at the same time. You need people to deliver the health system and the healthcare system as well. And then you need financing because somebody needs to pay for all the healthcare that you're delivering or the health that you're delivering. Thirdly, is a service delivery, meaning how you organize it. Do you have more hospitals or more clinics? Do you have more primary, secondary, or tertiary hospitals? And how do you finance all that? And how many people do you need in the service delivery component? And if I go down very deeply into a rabbit hole for service delivery, it would be to consider a patient in rural Malaysia. Let me invent a small village outside of Taipei called Batu Kurau, where they have lots of durians over there. So if you're interested in durians, you should really go to Batu Kurau. Batu Kurau, it's quite 30 minutes away from Taipei, and Taipei is an hour away from Ipoh, and Ipoh is the state capital hospital. Ipoh has an oncologist. Taipei does not have an oncologist. So if somebody has got a cervical cancer, for example, in Batu Kurau, how quickly can we get that person from Batu Kurau to Taipei and Taipei to potentially to Ipoh for them to receive a radiation therapy or cervical brachytherapy for the cervical cancer itself? I'm not talking about the speed of using an ambulance, yeah, 30 minutes plus 1 hour. I'm not talking about that. I'm talking about how fast through the system will this person take, especially if this person is less well educated, less financially well off, and perhaps less literate and does not want to take a lot of responsibility for health because there's an element of the doctors will decide for me because the doctors are specialists. And if service delivery in a narrow loop, narrow view, yeah, for the lady in Batu Kurau means that by the time she gets to Ipoh to receive cervical brachytherapy, she's already in stage 4. It means that the service delivery has failed. And that is one narrow view into what I mean by service delivery. Of course, I can go narrowly into workforce, for example, contract MOs, or how many nurses do we need? What is the right skills mix? I can also go very deeply into financing. What is the right mix between tax, insurance, and out-of-pocket payments? And what is the right mix to ensure that patients have got enough self-responsibility? For example, if you pay everything for them, then people will not take responsibility for their health. But if you ask them to pay something, then poor people will not come to the hospitals. So there is a very fine balance in the narrow rabbit hole of financing as well. Now, there are multiple rabbit holes, deep ones in each of the 6 building blocks, but unfortunately, we don't have the time for that. I'm only giving you examples. Let me move on to the 4th building block, and that is medicines, vaccines, technology, and services. And this is generally considered, shall we say, technology under the broad banner of technology. For example, excuse me, for example, we have NPRA, or National Pharmaceutical Regulatory Agency, that's based in Petaling Jaya, and they regulate which medicines can be used in Malaysia. And that regulation is a rabbit hole for you to consider how quickly or how slowly, how rigorously or how less rigorously will you want to approve a new medicine that comes into Malaysia. If it's a branded originator, patented medicine from big pharma like a Pfizer or a GSK, do you treat them differently versus if it's a generic from Dr. Reddy Pharmaceuticals in India or Chipla in India, for example? How do you treat them in terms of regulations? How strict or how loose are those regulations? How quick or how fast do you register these products? Let me make it even tougher. During COVID, should you register remdesivir or hydroxychloroquine or any new vaccine that comes in, given that you don't have enough phase 3 randomized control trial evidence to approve these products in peacetime, not pandemic times? That's one rabbit hole into the fourth building block of health systems, which is medicines, vaccines, tax, and services. The fifth building block is actually information. And when I say information, it's not as simple as just how many % of people in Malaysia have diabetes. And the answer is approximately 25 or something like that % of Malaysians have diabetes, very high. Approximately 50% of Malaysians are obese, that's very high. But we're also talking about information systems from hospitals. For example, we have 145 hospitals. How many beds do we have in total? The answer is something like 40,000 beds in the public system in Malaysia. Oh, I'm sorry, 60,000 beds in the public system in Malaysia in government hospitals alone. Excuse me. Of the 60,000 beds in government hospitals in Malaysia, what is the average length of stay? Meaning the average person who comes into the hospital, how many days do they stay? Some are inevitably longer because they need a lot of care, but some can be shorter. And we should, in general terms, drive the length of stay to become shorter. And these are examples of the information that you can receive from the entire health system that hopefully will be managed at state capitals like Ipoh and Kuala Terengganu and Kuantan, but also managed at Putrajaya, and that using these insights from the information, determining, okay, maybe, for example, in hospital in Kota Kinabalu, for example, in Queen Elizabeth Hospital, the average length of stay, or ALOS, is very high. And the BOR, which is the bed occupancy rate, is also very high. So if the ALOS and the BOR is very high in Queen Elizabeth Hospital and is getting higher and higher in the last 5 years, then it's part of the strategic decision, maybe we need Queen Elizabeth Hospital number 2. And that's how you use the information to plan for the health system in the coming 5, 10, even 20 or 30 years. Finally, the sixth building block of a health system is leadership and governance. And leadership and governance is a very broad theme. Obviously, with the health minister, the director general of health, state health directors, with hospital directors, pengarah of HCTM, deans of medical faculties, and so on and so forth. These are all leaders. But one might also argue that every doctor is a leader. I remember when I was in a Greek hospital and I was working in Greek hospital for a short period of time, doctors over there are invited to Kenduri Kawin, and sometimes you are considered the guest of honor in a Kenduri Kawin. I've never been guest of honor in a Kenduri Kawin, but I've been invited to attend Kenduri Kawin because you're considered a local leader in your community. In the 1960s and 70s, when Malaysia began elections, a lot of anecdotes, these are stories which I hear. Rural populations, even urban populations, were not familiar with the idea of elections. They don't know who to vote for. Guess who they asked? They asked their doctors. Doctor, siapa yang patut saya undi ya? And then the doctor, I don't know what the doctor would say. Maybe give a suggestion or not give a suggestion, I don't know. But the point is that every doctor is a leader in the health system, but also the broader community in which you live in. And then there are all rabbit holes, for example, about governance, like the Malaysian Medical Council. Many of you are familiar with the Malaysian Medical Council, MMC, because of the issue of registration, starting housemanship, the annual practicing certificate, and then contract renewals, all of which are dependent on MMC. But MMC also governs the health system. For example, if you have a complaint against a doctor for any reason. It could be negligence, it could be harassment, it could be dereliction of duty, or any sort of these complaints, then sometimes they will, or rather all the time, they will go to MMC for them to manage. So it's not just MMC, there is a nursing board, there is a pharmacy council and the dental council, all of which serve to govern the health system as well. Ladies and gentlemen, these are the 6 building blocks of health systems. I've given you a bit of an insight into rabbit holes, right? About each of them, each of these 6 building blocks, and given you real life examples, hopefully mini case studies about each of these 6 building blocks. They don't exist in silos, you know, they don't exist in and of themselves, but in actual terms, they are very interconnected to each other, one to another, and so on and so forth. For example, workforce and financing, you cannot have a conversation about workforce without talking about financing, and so on and so forth. So therefore, ladies and gentlemen, these are the 6 building blocks of health systems, all very interconnected. And ultimately, we want to reach out to patient care. All right, we're at the stage in our conversation right now where I think I'll skip this slide. I'm happy to go to the case study number 1, actually, but I would like to pause here to see if there are any questions from the floor. I would like to unmute everyone. Let me see if I can do that. And if you have any questions as well, there's nothing in the chat group at the moment. Anybody has any questions? Let's see. Let's see if I can. Cik Syamsul dan Cik Bukhari, boleh tak kita unmute semua participant?
Dr. Koh nak minta apa?
Unmute supaya mereka boleh cakap.
Okey, saya cuba unmute participant Doktor nak unmute yang mana satu tu?
Semua boleh tak?
Kesemua Okey, saya cuba
Kesemua, ya. Ya, terima kasih. Does anybody have any questions or comments that they want to say? Okay, here's Amirul. Amirul, why don't you unmute yourself and go ahead?
Hello, Doctor. I would like to ask about the universal, sorry, what the C again? UHC, right? The UHC
coverage.
Coverage, universal health coverage. So I was wondering, is that something that is already available in any other country or in Malaysia in specific, or is it still a theoretical concept that we wish it exists?
Thank you, Amirul. Amirul, great question. And the answer is yes, it already exists in Malaysia. Yes, it's a theoretical concept that everyone wishes it exists. No, it is not adequate in Malaysia. Those are my short answers. Allow me to elaborate, Amirul and everyone. UHC is a moving target. What I mean to say is that once you reach the target, it moves further ahead of you. So for primary care, in general terms, Malaysia's already ticked the box. We have universal health coverage in primary care. So then we can say we have UHC in primary care. However, we don't yet have UHC in secondary care or tertiary care. Certainly, we don't have it to make sure that everybody will get the cancer therapy that they need. Therefore, we can't say that we have completely universal health coverage in Malaysia. In fact, I would say that no country in the world has complete universal health coverage for one simple reason being that healthcare is endless and bottomless. You can never do too many MRIs, too many PET scans, too many surgeries. And once you fix a disease, and even if you have perfect health, there's almost always something that you can invest in terms of healthcare. And you really cannot provide everyone in Malaysia with the latest PET CT scans in every public hospital in Malaysia, for example. So for that reason, Amirul, we already have UHC to some degree in Malaysia, but because it's a moving goalpost, we have to continue improving it. And it remains a theoretical concept that everyone wishes exists, but no other country in the world will ever have a complete universal health coverage. One more philosophical thing I might say about universal health coverage, Amirul and everyone, is to say that there's a philosophical element and a religious element to this as well. The political philosophy element of this is universal health coverage means you don't have to pay for healthcare, meaning it's not free. UHC doesn't equal free healthcare, because if it's free healthcare, there's an unintended consequence that nobody will care for their health. We will just assume that technology will save us, I will not care for my diet. There will be stents, there will be coronary artery bypass grafting that I can have, and statins that I can take, and therefore that these are very bad unintended consequences. Amirul, I hope I've answered your question.
Yes, thank you.
Yi-Xuan, thank you, Amirul. Yi-Xuan, go ahead. Maybe you'd like to verbalize your question, please.
Good morning, doctor. Can you hear me?
Morning. Yes. Yes, we can hear you.
Hello?
Yes, Yi-Xuan, we can hear you.
Oh, okay. Good morning, doctor. Can you please give examples of pros and cons of Malaysia healthcare system compared with other countries? Because since you have working in so many countries in the world.
Okay. Yi-Xuan, this is another great question, but I'll have to compress my answer because you know, the 190 something countries, I think, or was it 500? I'm not sure, but anyway, I think it's 190 countries that we have in Malaysia these days, in the world these days, and I can't compare Malaysia against to other countries. Yeah. So I'll begin by saying that in broad terms, Malaysia's strengths are number one, primary care. Primary care in Malaysia is it's very well developed compared to other countries. This has been a very conscious policy of developing the primary care since 1950s and 60s. And indeed, I have seen a document, a red paper that was a part of the Ministry of Rural Development that was signed by Tun Siti Hasmah. Yes, Tun Mahathir's wife and a former First Lady of Malaysia, when she was an MO in charge of a clinic kesihatan way back in the I think it was 1940s even, that a document that I cited. And even since the 1940s also, Malaysia has very consciously built a primary care network. So this is something that is a very strong pro for Malaysia. And this is in a physical sense, but also in the organizational and system sense. The second pro for Malaysia's healthcare compared to other countries is that the transition from primary to secondary and tertiary care is strong. In other countries, they access secondary or tertiary care without a gatekeeper function. Meaning, to see a specialist in Malaysia, you have to go to a clinic kesihatan right now. But in many other countries, you go straight to a specialist. And GPs or primary care physicians are deprioritized. When they are deprioritized, it means that a lot of people go straight into the specialist care, making specialist care very expensive. So Malaysia's second strength is to go, the transition from primary to secondary and tertiary care is a very smooth one with a gatekeeper function. That's the second pro of Malaysia's healthcare. Thirdly, Malaysia spends very little on health. Our health spending as a percentage of GDP is 4.5%. The number 10% I gave you is total government spending, 10% goes to health. But total economy, 4.5% goes to health. Why is the number smaller? It's because private money is coming in, and when you consider the economy, the private sector is larger than the government sector, therefore the number becomes 4.5%. For 4.5% of GDP, we get great health outcomes, which means that our health system is very efficient. And when I use the word efficient, it's in economic terms. And these are the three advantages that we have, Yi-Xuan, compared to the 190 or so countries that we have in the world. There are a few cons to Malaysia's health system. I won't say cons, I will say that these are gaps, right? That we have these strengths and we now need to concentrate on these gaps as well. The first one is to say that the health spending is unsustainable, meaning our Malaysian health system is not putting enough, we're not putting enough money into our health system and healthcare system, both public money and private money. This means that we must invest more in health, and that's one gap. I won't say it's a con, I'll say it's a gap. Other governments are spending 10% of their government budget on healthcare, but as a percentage of GDP, sometimes 7 to 15%. In OECD, I think the average is 11% of their entire GDP on healthcare. So we need to spend more on healthcare. Number two is to further strengthen primary care, because Malaysia is already quite going towards secondary and tertiary care as well. While I've said that primary care is strong, it can be stronger. Why? Because the gatekeeper function needs to be strengthened so that the secondary and tertiary care will be protected. And if I can say a third gap in Malaysia's healthcare system right now is inclusiveness, and not physical access, but financial access, including for people who are non-citizens in Malaysia. Yi-Xuan, those are my summaries about the pros and the cons, or the strengths as well as some opportunities for Malaysia's healthcare compared to other countries. Thank you, Yi-Xuan. Putra, if I may, would you like to verbalize your question?
Good morning, Doctor.
Morning.
Yes, I would like to ask, what is the current update for precision medicine in Malaysia? Thank you.
You're welcome. So for everyone else, what precision medicine means is a medicine, or rather the field of medicine that is highly targeted to the individual's genetic characteristics, genomic characteristics, biological characteristics, also the social and economic environment in which the patient lives. What I mean to say is this: if you see 10 patients with Hello everyone, I'm back again. Can I just check that you can hear me? Sorry, I missed out for a few seconds.
Hello, dah okey dah.
Okay.
Tadi lag sekejap, tak tahu kenapa.
Oh, sorry. Terima kasih, Cik Bukhari. Putra's question, ya, soalan daripada Putra tadi berkenaan dengan precision medicine, ya. So I will proceed. And in the meantime, I'll share my screen as well. Okay. I hope you can see my screen. I hope you can see me as well. You can hear me. Putra, I was saying about precision medicine that it means different things to different people. And what it generally means is you give a medicine that's targeted to the genetic profile of that particular patient. It could be genetic, it could be the biochemical profile, it could also be the immunological or histochemical profile of the disease in the patient. I'm not an expert in precision medicine, but I'll give you some brief answers by saying, firstly, it is not well developed in Malaysia. In fact, it's not well developed in many other countries as well, because we're still testing this out and we don't have a clear definition of what is precision medicine. Secondly, to bring it to Malaysia requires a few hurdles at the same time. The first hurdle is actually the regulatory hurdle, or rather the scientific hurdle. You have to prove that the science checks out for precision medicine. Then the second hurdle becomes a regulatory hurdle. Just because the science checks out doesn't mean that it must be or can be or should be accelerated in terms of its registration for use in Malaysia. It must be approved. So the first hurdle is scientific, second hurdle is regulatory, third hurdle is commercial. It is often very expensive. You have to send the profiles for testing in labs in various countries, and the results will come back in a long period of time. You may need data science and artificial intelligence to help you process this information. So there are commercial considerations as well in terms of the launch of precision medicine in Malaysia. Putra, thanks for your question. I hope I've answered it. Let me just try to get one more. Some great questions, but I do have this case study that I hope we can do. Kaishan, would you go ahead and verbalize your question? Go ahead. Oh, as in you can speak if you can. If you cannot, I'll just wait another 10 seconds. And if you cannot, I'll read your question out.
Hi, good morning, Dr. Kaur. Can you hear me?
Yes, can hear you. Good morning.
Question is how and what would be the impact on the Malaysia health system imposed by the health insurance? As we can see, like in Taiwan, they are mostly like resolved around the health insurance for their medicals, consultation, and also the fee. So for Malaysia, I don't think that we have a very good health insurance. So will that be impact on our primary access care to the medical health and also the medical coverage?
Kaishan, this is a great question. So I would like to use a slide. So I will, how do I do this? I will create a new slide and I will write some things over here, okay? So that you can all see it. So Malaysia, to answer your question, thank you for your question. So I'll say 50% tax, 40% out of pocket. 10% insurance. Okay, these are the terms that I would like to use when I answer your question. Yeah. So the first thing I'll say is that currently, today in Malaysia, of our total healthcare expenditure, or where do we get the money, right? The sources of funds, and then how we use it is a separate matter. We will not discuss this in this question. We're talking about the sources of funds and then the users of funds. You get the source and then you use the fund. In the sources of funds, what we have is that 50% of our sources of healthcare funding comes from general taxation. 40% of it comes from out of pocket, which is why many Malaysians go bankrupt because of medical costs. And the 40% out of pocket means you go to a private hospital, you pay out of your own pocket from your savings or your salary, or you go to a private pharmacy, you pay out of your own pocket as well. And usually it's one person, meaning you, the patient or the patient's family, paying in a private hospital or a private clinic or a private pharmacy. And that's 40% of all healthcare dollars that's spent in Malaysia. 10% of it comes from insurance. So you buy it from AIG, from Great Eastern. When I give you the names of these companies, it's only to illustrate. It's not to recommend or to endorse any of these companies whatsoever. I have no interest or no shares in any of these companies whatsoever. But just to illustrate some examples so that you understand it. In other countries, the percentages are different. There is no globally accepted perfect percentage, meaning X% tax and Y% out of pocket and Z% insurance. No country will ever tell you, or no organization will ever tell you, this is the perfect percentage for you to aim for, because it depends on the countries. So for example, in the UK, it's 95% general taxation, almost 0% insurance. Okay, that's not true. Many rich people buy insurance, but the point being that only 5% of expenditure in the UK comes from out of pocket and insurance. The rest of it is all heavily taxed. Germany is almost all insurance, so is Japan, so is Thailand, and so is Taiwan. When I say almost all of it, I say it's about 50 to 70% of it, and then the rest of it is general taxation with a small amount of out of pocket. So this is the situation in Malaysia right now. Also the pros and cons, not pros and cons, but the difficulty in achieving a perfect response. Your question, Kaishan, is about the impact of health insurance. And I will introduce 3 concepts over here that I would like you to maybe just write down, and you can Google and you can read more about this. And it's well beyond each of these, right? It's a 1-hour lecture. And some people study this for an entire PhD. I will not be able to give you, I don't have the time to give you at the moment, what is adverse selection and what is moral hazard and what is public option. But here's a brief idea. Let's just say you are the CEO of an insurance company. You want to have as many people as possible buy the policies of your insurance companies. But in general terms, only sick people want to buy insurance, or those who fear that they will become sick. Healthy people, young people like you and I won't buy insurance. That is adverse selection. When you have a lot of sick people wanting to buy insurance, the premiums will obviously go up. When young and healthy people don't want to buy insurance, the premium will also go up. That is the problem of adverse selection. The problem of moral hazard is when you have bought insurance, let's just say you're young and you're healthy and you buy insurance and you think, if anything happens to me, somebody will pay. And therefore you will start taking risks. For example, you will ride your motorcycle very, very fast without wearing a helmet. And when the police tries to arrest you, you will drive even faster. Why? If you have an accident, somebody will pay for your medical costs. Or I don't care about my diet. I won't exercise. I'll eat McDonald's every day because I know if something happens to me, then somebody will take care of me and pay for my medical expenses. Those are moral hazards, and that's the disadvantage of insurance. Often the conversation around insurance in Malaysia is that if we expand the use of insurance, then private companies like AIA or Great Eastern or what have you will benefit. But in many other countries like Germany or Japan or Korea or Thailand or Taiwan, there is the public option of insurance, which is what Obamacare in the United States tries to do. America is a very insurance-driven healthcare model, but insurance is all private, for profit, with large profit margins. But the public option of an insurance company could work in a country like Malaysia. Who is the insurer? The Malaysian government. Malaysian government creates a new company owned 100% owned by the Malaysian government. What is the intention of the company? To insure Malaysians, but not to make a profit. If you do make a profit because you're highly efficient, then the profit plows back into the population and not to shareholders or people who buy stock in AIA or in a Great Eastern. So the impact of insurance in Malaysia are, as I've described to you, there is a role for insurance in Malaysia, but we need to consider a public option. Allow me to move on to the next question. Kashan, I hope I've answered yours. There's a lot of questions over here. I would like to maybe ask people right now, right? So I do have this case study. So maybe, let's see, let me check the time a little bit. I'm really glad for all these questions since they're great questions. We've got 20 more minutes. What I will do is just do one case study. We'll do 10 minutes of that, yeah? And then if it's, I'll take 1 or 2 more questions from the chat group now. We'll do a case study, just one of the 2 case studies, and then we'll return for some more questions and answers. I hope you're all okay with that, yeah? Okay, sorry, I think you might be a bit mute, so I will just proceed on the assumption that you're okay. I will, Ishan, if it's okay with you, I will just skip your question for a while. I will go to Marjorie's question and Noor Mahira's question. I think Noor Mahira has raised her hand. I'll be interested to hear what she says right after Marjorie, yeah? Marjorie, give me a second, I'm going to read this. Okay, Marjorie's question is about behind the scenes specialists that are in charge of calculating the perfect balance of the trilemma. Marjorie, if I may, I'll proceed to my answer to your question. The first one is there's no perfect balance. Okay, let's set that aside. Number 2, therefore, there will be no calculation, but there will be trade-offs and discussions and negotiations. And thirdly, I will say that in the landscape of people who make these decisions about the right balance, there are the specialists, those who, for example, spend their lives trying to study this, and they do PhDs in health management, and I love these people, they're my colleagues, and there's one group, the academic specialist public policy practitioners, and I'm trying to be one of them. The second group will be the technocratic leaders, and we're talking about people like Director General of Health, Deputy Director General of Health, there's a second group. The third group will be political leaders like health ministers. And in a democracy like Malaysia, there is, or rather in any country in the world, there is no one perfect decision-making process. Do you trust experts and specialists only, and there are no politicians at all? In which case we might not need elections, or if we elect the experts, we don't elect politicians. Now, I'm not saying one is better than the other. This is an entirely long conversation. I want to reflect the neutral reality to you, Marjorie, and to everyone else, that the politicians often come in and they have their own decision about what is the right balance between quality, access, and cost. And different politicians or different political parties and different political coalitions at different time points in Malaysia's political trajectory will have different opinions about how much you want to invest in quality or access or cost. And every answer is good and bad at the same time. So given these 3 landscapes, right, the experts and academics and technocrats, the leaders inside shall we say, more political leaders inside the Ministry of Health, like the DG of Health and the Deputy DG of Health, and thirdly, the politicians will come together in meetings like a Rancangan Malaysia ke-12 or the annual planning meetings for Ministry of Health, or even the budget 2020 or 2021 exercises in order to allocate this money or political capital. And therefore, it's a result of a lot of evidence and consensus building and negotiations as well. So it's the behind the scenes one, I think, is an entirely separate conversation, obviously. But there's no science to this. It's a very art. There's a lot of art in the process as well. And you're right, many papers on these statistics are not accessible or easily online. They're not transparent. All this is very true. Mahira, if I can move to you, I'll be happy to hear you. Go ahead, Mahira, and say some, verbalize your thoughts. Mahira, you may have to go unmute if that's okay. Or alternatively, Noor Mahira, maybe you could type your question in the webinar chat. How about that? Okay, and I'll get to yours immediately after the case study. Okay. Sorry, Mahira. I hope you don't mind. Yeah. All right, so we will go back to this. Let's see. Yeah, I'll do case study number 2. And in case study number 2, it is, give me 1 second. I need to think about this for a second. Yeah, case study number 2. Okay, we'll do case study number 2, ladies and gentlemen, because it's a little bit more precise. We'll spend maybe about 7 minutes or so on this case study. Sorry, we have to rush a little bit. But maybe the next sessions, I will dramatically reduce my speaking time and just take your questions, yeah? All right, case study number 2 begins like this. You have 1 billion ringgit to spend. You are the health minister, let's just say, yeah? Or the director general of health, something like that. You are in possession of 1 billion ringgit of taxpayer money for you to spend. These are the 5 questions. What are the data points? After I read the 5 questions, I would like to volunteer 1 person for an answer. Yeah, so you'll answer all 5 questions, and any 1 person who feels that they want to try to answer all 5 questions, go ahead. Okay. And really, there are no right or wrong answers. Let's just talk through a thinking process. Okay. There's nothing to memorize. Nothing about the glomerulonephritis, for example, for you to memorize. But all these things are very abstract and therefore require every answer is a good answer. You have 1 billion ringgit to spend. You are the Minister of Health. You're presenting a paper to the cabinet or to the parliament. And these are the 5 questions in front of you. I would love for 1 volunteer later to just spend a few minutes talking through this. And then we'll have a conversation about this for 7 minutes. All right, first question is, to spend 1 billion ringgit, what are the data points that you will use? And after the data points, just list down 3 or 4 data points that you use to decide what will you spend this on and why. And let's assume that you spend this on one of the 6 building blocks, for example. What are the intersections with other building blocks? For example, if you're spending in service delivery, the intersection is with workforce, for example. And finally, I want you to think about what are the unintended consequences. We don't think, we as policymakers don't think enough about unintended consequences. We always think our policies are the perfect policies, when in fact there are also problems with every policy that we propose. My point being, think about the unintended consequences. So maybe I'll invite all of you to spend a minute or 2 quietly to think about the answers to this question, and I'll take the first volunteer in the chat group. Please say I volunteer. This is a great opportunity, and please, I would love to hear a volunteer. Otherwise, I'm going to have to pick names, okay? How about another 30 seconds? Still no volunteers. I'm going to have to start picking names. Again, still no volunteers, unfortunately. I'm gonna have to start. Oh wait, let me check. I will pick a name. Yi Xuan, a data point could be you want to know what is the number of patients in Malaysia who cannot access cancer therapy in breast cancer, for example. That is one example of a data point. Another example of a data point would be which state in Malaysia or which region of Malaysia has got the highest number of non-communicable diseases, all combined: heart disease, pulmonary diseases, diabetes, obesity, and so on. That's the second example of a data point. Ladies and gentlemen, I'm going to start picking names here. I'm thinking I would like to call on Rasika Shankar, please. Rasika, if it's okay with you, could you unmute yourself, please, and maybe tell us, you are the health minister and you have R1 billion. Can you just provide us your answers to the following 5 questions that's on the screen? Rasika, we will be happy to listen to you. Rasika? The fun part about this is that technology makes it difficult for me to see if you can or cannot speak. Rasika, can you indicate in the chat group at least whether or not you're able, you'd like to take this on? Okay, not a problem. That's all right, Rasika. We'll move on to somebody else. Perhaps Muhammad Nabil Fauzan Jamaluddin. I'm really picking random names, yeah. Nabil, salam. I hope you don't mind. Why don't you take us through your thought process about spending this R1 billion?
Salam ke? Yo, you can hear me?
Yes, jelas. Teruskan. Go ahead.
Right. Given R1 billion, it's quite a huge amount. On the first basis, I think the data point that I would like to see is how well is our previous allocation, our money allocation was being used in terms of our health system, our staff and care workers payment, and as well as how good can we sustain our hospitals punya maintenance. Some of the points. And how should I spend this? I would like to see, especially in our service delivery, since the service delivery and as well as the workforce, it represents our background works. The financing, our medicine, our vaccine is all behind our background things that the patient will not see. But the service delivery, I think, is the most important one, as the patient can tell and can make an assumption at how good or how well we manage our facilities. And in terms of intersection, if I would like to increase more toward the service delivery, maybe so as example, to improve the service delivery, to improve their work performance, maybe we have to increase their salary, itu as example, or ada another thing, maybe we could provide them with accommodation, better accommodation, and also at the hospital itself for them, so they have a better environment. And in terms of intersection, indirectly workforce have to be increased. Is in our data point says that we are lacking of staff or we are understaffed, so we have to increase our staff in order to increase our workforce, and eventually our service delivery might be improved. And unintended consequences, if I take my example just now, where we increase their salaries, there might be a pool of people that are trying to change their position from other department, and the pool of people are trying to go into the service delivery or workforce punya. Instead, so and eventually we will have understaff or under workers at other department as well. I think that's all from me.
Thank you, Nabil. It's an excellent answer. Thank you. Anyone else with any thoughts about what Nabil has shared? Maybe you want to add on to what he said, and anything else that you want to share? Anyone else? Well, how about Nabil? I really enjoy your answer very much, right? To the extent that I would like to maybe call on one more person to share your thoughts about this. Yeah. So I'm just scrolling down the list right now. How about Ifah Farzana Muhammad Fawaid? Salam Ifah. Ifah, I hope you don't mind that I'm just calling on you, perhaps not by surprise, hopefully not by too much surprise. Ifah, why don't you tell us a little bit about how you will spend this 1 billion ringgit, using those 5 questions as a bit of a guide. Ifah, go ahead, I'd like to listen to you. Ifah, you may have to go off mute. Ifah, I'm not sure I can hear you. Okay, not a problem. We'll just move on to another person, maybe. Maybe one final volunteers. Anyone who wants to volunteer to share any more thoughts about case study 2? No problem, Sifa, that's okay. Okay, so we've finished our case study 2. We've got 6 more minutes until 11:30 a.m. Would you like to do case study 1? This will be something that we can do, or maybe I'll spend 1 or 2 minutes on case study 1. But in the meantime, if you have additional questions, for example, Numahira, I haven't seen your question on the chat group yet, but if you have an additional question, then let me know. In case study 1, I wanted to ask these questions. Nobody has to answer case study 1 here, but in case study 1, I wanted to ask you the questions for long-term reforms, meaning, in your opinion, who would be the actor for long-term health reforms in Malaysia? And I'll give some stock answers, right? Ministry of Health, JPA needs to be part of the long-term health reforms. Ministry of Economic Affairs or Economic Planning Unit needs to be there as well. Fourthly, we need to consider the Prime Minister's Office or some central agency to have long-term health reforms. And certainly we need the Doctors Lobby, Malaysian Medical Association, Academy of Medicine Malaysia, and Malaysian Nurses Association, and so on. These are the actors for long-term health reforms. But among the landscape of actors that are very crowded, who are the major decision makers, meaning who will be holding the most power in making those decisions or the most influence in making those decisions? Now, when I say decisions, it's as though there's one person who makes all the decisions. That's not true. Some decisions are made by some people, other decisions are made by other people. Because this health system is so large, we will see multiple decision makers making decisions in multiple areas. And in each of these areas, there'll be multiple major decision makers as well, rather than one solo single person deciding for all of Malaysia. Then I wanted to ask you this question number 3. We can reform so many things, like Nabil's excellent answer just now, where you want to focus on service delivery, but then you see connects with workforce, it connects with accommodation for doctors and so on, right? So what's the one reform that you want to implement? There are many things that I'm sure you can implement. What is the one thing that you want? And number 4, what is the smallest, most feasible change to the system? When I say feasible, I mean politically feasible, economically feasible, and bureaucratically and administratively feasible. Because we can say, I want world peace and I want no nuclear weapons. You know, it's a beautiful concept and a beautiful dream, but at the moment, it's not politically, economically, or even administratively feasible. So in Malaysia, for the health system reforms or strengthening, what is the smallest, most feasible change to the system that we can adopt to stimulate ripple effects? Meaning you have this one change. For example, it could be build better housing for doctors and nurses in rural postings in anywhere, Sabah, Sarawak, Perak, whatever else, so that once you build that, it is small, it is politically feasible, it is economically feasible, it is administratively feasible, people will support this. Once you build better housing, then it's easier to attract doctors to go to the interior, and that will have ripple effects on so many other things. So find the smallest, most feasible change to the system that can then have ripple effects that can last a long, long time. And finally, as usual, when you think about reforms or any changes in any policies, you must consider the unintended consequences of anything that you do. All right, we've got 2 more minutes, everyone. Maybe I will just look again at the chat group. Does anybody have any final questions at all? Go ahead and type it out in the chat group or raise your hand. Amirul, thank you. Great question. Amirul, I'll answer your question very shortly. And we've got one hand raised. Yi Xuan. Yi Xuan, go ahead.
Good morning, doctor.
Hi, I can hear you well. Good morning.
Doctor, so I feel that today's content is like a very huge perspective on global health. So do you have any recommendation of platform where we can learn more about this?
When you say this, you mean health systems or global health?
Yeah. I think I'll start from global health first. It means today lecture, the healthcare system, because this is so huge syllabus.
It is. So one of the recommended readings that we have is the 6 building blocks of health systems. If you Google, it's in the course content, yeah, so the course description, the 6 building blocks of health systems, and there's a good document by the World Health Organization, and you can read that document to truly understand the 6 building blocks of health systems. I think this is a good way to start. What I would like to do is maybe recommend you one article to read as well. And you know what? I will have to show you on my screen this article. Conversation. Oh dear, what's his name? Wait, I'll search for the exact article for you. And maybe is there how do I connect with all of you by email? Is that possible?
Yes, Dr.
Yes, go on. Who was that?
Me, Marjorie. Yes.
Yes, Marjorie, go ahead.
Previously, Encik Bukhari sent the course synopsis, so I think that you can follow up with all of us with an updated file or a few more references for this.
Sure.
Yeah.
I can do that. So I'll send an email to Encik Bukhari. Encik Bukhari, izinkan ya saya emailkan Encik Bukhari with 1 or 2 links, and then we can send it to the students. Or Prof. Rostina, you want to say something maybe?
Sorry, are we at the end of the session already?
Yeah, we're just about taking Q&A. Yes, we are at the end of the session.
Okay. Now, if you want to close your lecture, then I'll just say 1 or 2 things. Done?
If I may, what I'll say is the following. Prof. Rosina, allow me to just spend 1 more minute. To Yi Xuan's question and to Amirul's question of anything we can prepare for next week's lecture, maybe we should establish a way that I can be in email contact with all the students in a group email, where I'll be able to send some thoughts and some follow-ups after the questions and answers that have come up. For example, Manika Mangai has just sent me a question, which is a great question, which I don't have the time to answer right now. So if we can establish a bit of a direct link, that'll be helpful. So that's one. But number 2, Yi Xuan and Amirul and everyone else, the amount of material out there is very large. I prefer, in a way, not to make recommendations to you, but for you to discover this material by yourself. There are ideologies at play, meaning some people believe A is better, some people believe B is better. And I have my opinions about whatever A and B is. So I don't want to influence your opinion by giving you something that leans towards A or leans towards B. You should still be very free to find out your own positions about your on the ideological spectrum. The point being that some of those elements and thoughts and terms that I provided to you, right, are things that you can read further as you take notes. And when I use these different terms, you can put them onto Google, and then you can read one side or both sides, however much you want, and you figure them out yourself. So the first thing is to say that if I can open a channel to the students through Cik Shamsul or Cik Bukhari, that'd be wonderful, and I'll provide some initial thoughts. But secondly, we must rely on the students being self-reliant, yeah? So you figure out what you want to read as opposed to me giving you the recommendations all the time. So we'll find a mix of both, yeah? Amirul, Yishan, and everybody else, okay? Prof. Rosina, sorry. Thank you very much, everyone, for being here. I really enjoyed your questions. Manika Mange will connect with you separately, or please connect with me separately. And I look forward to seeing all of you again on a Saturday next week. Prof. Rosina, over to you.
Thanks very much, SK, and kind of express our appreciation for your time every Saturday. It's been an excellent lecture, and I just want to say to the students that I've been very impressed with your questions and your participation, really. And I think rugilah kawan-kawan yang tak datang. So I hope you can promote this to your peers. And I know we said that you get a certificate of attendance if you attend all 4, but I look into ways of seeing how perhaps they can make up for this session. So if they attend the next 3 and perhaps watch a video recording of this session and maybe submit some Q&A, if Dr. Kaur doesn't mind, then perhaps they can be eligible for the certificate as well. And it should be no problem to set up a email group for further interaction online. And perhaps in future, we can look into using software such as Padlet, which actually allows the lecturer to continue interacting with the students even after the lecture is over. So we can improvise on this. And I'd just like to say thank you again. And thank you to all the students and to Cik Bukhari, Cik Sham, everybody who supported us today. We look forward to seeing you again next week. Thank you very much.